anticonvulsant drugs. What I want to do is go over the questions that you guys had this morning. So let me just start reading those and give you the answer. So question number one was levothyroxine is A, T3, B, T4. The correct answer is B, T4. Remember that T3 is the active component, and so basically what we're doing is we're giving T4 and then it gets broken down into T3. Two, radiolabeled iodine is used in the treatment of A, hyperthyroidism, or B, hypothyroidism. And the correct answer is A, hyperthyroidism, because the iodine basically gets sequestered in the thyroid gland, and the radiation then kills the thyroid cells, which then decreases the thyroid production. Three, hypoglycemia occurs when circulating insulin levels are too A, high, or B, low. And this is, the correct answer is A. And what happens is when insulin levels are elevated, what will happen is basically that drives the glucose into from the blood into the tissues. That's why you get the hypoglycemia. And finally, hypoglycemia leads to a blank state. And you had a choice between hyperadrenergic and hypercholinergic. Correct answer is hyperadrenergic. That is due to the basically the autonomic nervous system. That's where the tachycardia and the sweating and so forth. That's the things that we talked about right before we broke for lunch. Okay. And again, these answers, I think they'll post them with the questions a little bit later. So that's what we'll probably see there. Okay. Anybody have any questions? Okay. All right. So the last part of this weekend, we are going to talk about anticonvulsant drugs. A couple of things in particular about the anticonvulsants is, one, there are some potential drug interactions which are going to be directly applicable to you, and which I'll point out. Secondly, several of you will be prescribing some of these drugs as mood stabilizers, and we will cover them with regard to their mood stabilization and so forth when we talk in the advanced course. So let's just go ahead and begin with with this. And so when we're talking about anticonvulsants, typically we're going to be talking about anti-seizure meds, okay? And there is a lot of debate with regard to, I've just dealt with a couple of cases in the past couple of weeks of where people had died, and there's a lot of miscommunication among the healthcare workers with regard to, some people saying they had epilepsy, other people saying seizures. So there's been a lot of information. I've also seen in the last month 2 or 3 cases where that individuals have, for example, we had an individual that was working all day long, and basically what happened is that he had been working in a shopping center, in a store, and they were installing workout in their parking lot. And what happened was he had been working with the same guy all day long. He had dropped the guy off at one end of the parking lot, went around the store, was coming back to pick him up, and the guy apparently had a seizure and blacked out, and basically his car ran into the back of a chain restaurant, hit the grease pit, and there's major legal issues going on because there was several people that were, no one died, but there were several people that got burned and had some pretty serious injuries. And he had taken some NyQuil the night before, so everybody's trying to say he was hooked up on NyQuil. And what we discovered was he had a little bit of NyQuil in his system, but nothing that would be that, and there was no indication. So it appears to be that he had a particular seizure, and the problem is that they're having a hard time exactly diagnosing the type of seizure. So just an example of where the things that come up here. So let's just talk about, we're going to talk about anticonvulsants, but we're really talking about anti-seizure medications. One of the biggest things that we worry about is when people have seizures. It's very important to identify basically make sure you get the right classification of seizure. And the reason for that is, as you will see over this afternoon, is that one thing is that there are certain drugs that work on certain types of seizures. There are other types of drugs that work on others, and many times one drug may not work on the other. So sometimes when people think they're getting seizure control, it's that the drug may have worked, but what they've possibly done is they've just basically tried to sedate the person by using real high dosages. The other thing is, getting around to the high dosages, the other big issue that we're dealing with is that we need to keep these dosages. Several of these anti-seizure medications, in general, anticonvulsants or anti-seizure medications are, in general, CNS depressants. And so one of the things that we have to do is to try to find where we get good control of the seizure. There's two goals that we're really wanting to try to accomplish. One is if the person is undergoing a seizure, one thing we want to do is we want to try to stop the seizure. The second goal is that once we diagnose someone with a seizure, we want to try to use drugs to prevent another seizure from happening. So we're dealing with one, stopping, and two, from a prophylactic standpoint. So one of the things that we have to do is to try to find a drug that we can get good control and get good seizure control, and basically use a dose that is low as possible, because there's a lot of ramifications. If we got too low of a dose, the person has another seizure, there's a lot of legal ramifications that's there. Legal ramifications from the standpoint of what happens if they had an accident while doing this. Second ramification is if we have chosen the wrong drug, one of the things that may affect their quality of life and their livelihood, because one of the issues may be is that when they have a seizure, they have to generally be documented to be seizure-free and under control for a significant period of time. I think it's a year. And that is going to be a very important thing to do. Plus the concerns of, what happens with a seizure. But what happens is if we use the right drug, we tend to be able to use lower dosages. And if we use lower dosages, then we tend to have less chance of toxicity. Doesn't mean that we're completely free of toxicity, but it may mean that the toxicity is something that the patient can live for. What we see is that, this gets back to the seizure classification. We find that for the partial seizures, pretty much the drugs used for those are pretty similar. For the ones that are generalized seizures, then we become more selective. We have to pick the right drug for that. So that is one of the things that we have to take into account. So one of the big things when we talk about seizures, epilepsy comes to mind. And what we see is it's estimated that probably the existing drugs provide adequate seizure control in about 2/3 of the patients. Okay, doesn't necessarily mean that the drugs are producing, that there's not issues with those drugs, because we do have seizure control, but some individuals may be dealing with significant side effects that are associated there. There are some patients that have epilepsy that they seem to be resistant to a wide range, to almost all available drugs. Most people have suggested that is due to in those particular patients that seem to be resistant to everything, is that there's an increased expression of the multi-drug transporter, which is P-glycoprotein 170. This is one area that's real hot right now because of the potential for dealing with seizure that's there. And so this is one of those polymorphisms that may be an issue that we're need to be aware of. So when we look at the overall therapeutic strategy, what we want is, we have to realize that I'm not aware of any anticonvulsant. I've got this qualified statement for most anticonvulsants. I'm not aware of any anticonvulsant which basically we can correlate the blood levels and the therapeutic effect. What we find is that when you look up the literature, and with regard to this, they will not say there's no correlation between blood levels and therapeutic effect. But what we do see is they give what is called the therapeutic range. So, for example, they may say that the therapeutic range for lamotrigine is 50 to 200 micrograms per milliliter. Okay. And I just pulled that number off the top of my head. It is not what lamotrigine's therapeutic level is. What that basically is that people that are taking the drug and that seem to be, being controlled, this is the range in which we see their blood. So we see what is called a therapeutic range or a therapeutic level. That does not give us a correlation with seizure control. It simply means with these anticonvulsants that we have ranges, and this is that people that appear to be controlled that are taking the drug at the doses recommended, that their blood level should fall somewhere in this range. That's all it can really tell us. So when I'm saying that the relationship between blood level and therapeutic effect is not characterized, is true. So what we find is that we have a therapeutic range. Okay, so for most anticonvulsants, the blood levels and therapeutic effects are characterized with regard to a range, not a correlation there. We do know one of the problems is that the therapeutic index is relatively low. What I mean by that is pretty much we are anticipating that there's going to be some significant toxicities that we need to be aware of. We have characterized the pharmacokinetics for these drugs fairly well, for most of them, and even in many specific populations and situations. So we do know that. All right. So one of the things I'm going to tell you is that we're going to see a bunch of drugs this afternoon. Okay. I don't want you to be overwhelmed with the drugs. What I've done is sort of highlight the drugs that we're going to use. I'm not going to be asking you a question of like which drug is used for a partial seizure, which drug is used for this type of generalized seizure. So basically, I want you to be aware of these as anticonvulsants, and I want you to be, focus on the areas in red. But again, there are a lot of different drugs that are out there, and I've tried to pick the ones that are either prototypical of what we're talking about or that may have significant actions that you may need to be aware of. So when we look at the anticonvulsants in general for their anti-seizure or their anticonvulsant activity, we see that the things that we're running into is, as far as mechanisms, fall into these general categories. One is they may enhance GABA transmission. Okay, one of the things that we see is that GABA is an inhibitory transmitter, and glutamate is an excitatory transmitter. And we do see several of these drugs that what they do is either increase GABA release or block the breakdown of GABA. But the net effect is we seem to see an enhancement of the inhibitory transmitter. Makes sense. We think of a seizure as being an excitatory effect, so we would want something that sort of puts the brakes on. We also see some of these drugs may actually decrease excitatory transmission, usually it's glutamatergic. So a lot of them will inhibit the glutamatergic activity. So either enhance the inhibitory, i.e. the GABA, decrease the excitatory, typically the glutamate, or the other thing we see is a lot of these will modify ionic conductance. So when you think about it, with the ionic conductance is that the electrical potential that is developed on the cell membrane is due to the different charges across the membrane. Just like other cells, when they depolarize, we have sodium and calcium and potassium and chloride and those ions exchanging. It makes sense that one of the ways when we are having excessive electrical activity, it makes sense that basically that electrical activity could be modified from a standpoint of affecting the conductance across the cell membrane. So when I told you there was going to be a whole lot of drugs, this is an example. So the drugs that are used as anticonvulsants, both for partial and generalized tonic-clonic seizures, we see a lot of these. And so, you know, we'll pick some of these as we go through to focus on. So there'll be some we'll talk about. The drugs in particular that you might want to be aware of specifically, which we will talk about a little bit more in detail today, but also later on in the advanced pharmacology class. But for example, carbamazepine, Tegretol, that's a drug that you would potentially prescribe for mood disorder. Some people have suggested drugs like oxcarbazepine, which could be, has been suggested. We've seen gabapentin, topiramate, lamotrigine. These are all ones that have been identified. We'll probably go into more detail with. So let's start with one of the prototypes for the seizures, which is phenytoin. Interestingly, years and years, this was known as diphenylhydantoin. And then they changed the name to phenytoin. It always surprised me. Diphenylhydantoin sounded more pharmacologically adept, if you will, or more pharmacologically sound than phenytoin. Phenytoin seems like you bought the cheap drug. But phenytoin is a very common anticonvulsant. It has a lot of different properties. It does alter the membrane potentials. So it's going to alter, any drug that alters membrane potentials is going to in some way alter or modify sodium, potassium, calcium, or maybe even some other ions conductance across that membrane. Phenytoin also has been shown to alter amino acid concentrations. Some of these may be excitatory, some inhibitory. In particular, there's been GABA, which is inhibitory, but there's been some evidence that norepinephrine and acetylcholine may also be affected. But with phenytoin, it will bind to the sodium channel. And when it binds to the sodium channel, it tends to make it stay in an inactive state for a longer period of time. Phenytoin also, when it binds to membranes, tends to stabilize the membrane. And so when you look at the potential mechanism of action, there is a number of things, everything from membrane stabilization, alteration of GABA concentration, so enhancing GABA, stabilization of the membranes, keeping the membrane in the inactive state for a longer period of time. So a lot of potential mechanisms. When we start getting at high concentrations, we start seeing that it will affect release norepinephrine and serotonin. It can cause an uptake of dopamine. It can inhibit monoamine oxidase. But those are usually at very, very high concentrations, not what we see clinically. It reduces calcium permeability and therefore inhibits calcium flux going across. So that can affect the electrical properties of the cell. That fits back up there. But when we look at it at the therapeutic concentrations, the range at which we see most people being at when they're on the dose as prescribed, the major action of phenytoin seems to be that it blocks sodium channels and basically keeps the these repetitive action potentials from keep on firing. It blocks that. So that makes sort of sense from a standpoint is that it's basically sort of like a local anesthetic. So it's basically blocking sodium channels. If the sodium can't come in, it makes it difficult for the cell to polarize. Maybe not as much sodium comes in, so it may not depolarize as much. But we think that at therapeutic range, at therapeutic concentrations, the major effects seem to be due to the blockade of the sodium channels. It is a very effective drug. We still see it used quite a bit. Not only do we see it used for partial seizures, but we see it used for generalized seizures, especially tonic-clonic. One of the problems with phenytoin, some of the problems with phenytoin actually revolve more around its pharmacokinetics, if you will. One is phenytoin, most drugs undergo first order kinetics. Phenytoin goes under
zero order kinetics, which basically is we see phenytoin and alcohol, so only a few drugs will undergo zero order kinetics. But what that means is basically that its absorption into the bloodstream is very highly dependent on the dosage. So when we change the dosage form, this can have some big issues. Now, there is a derivative of phenytoin, I should say derivative prodrug of phenytoin, which is called fosphenytoin. Basically, we find this being used a lot instead of phenytoin. One of the things with phenytoin is that it is not real soluble in water. So what we typically have to do is to dissolve it in another liquid. And one of the problems can be is some people think some of the side effects that we see in these patients is due to the solvent or the diluent. Fosphenytoin is actually much more soluble and can be and is absorbed pretty good after IM administration. So many times we use fosphenytoin because it's more soluble and more predictable, and it gets converted to phenytoin. Phenytoin is pretty highly protein bound, so we have to worry about drug interactions, and it does accumulate. It does get into the tissues, so we'll see it getting in the brain. It can also get in the liver, the muscle, and the fat. So there's plenty of places that this drug can reside. So here's the thing is that we have is with phenytoin. At low blood levels, we use what is called, it undergoes at first order kinetics, which is like most drugs. But what happens is that as you increase the amount of drug that's being given and the blood levels rise, what we see is that the liver sort of maxes out as far as how much it can metabolize. So because of that, a small change in dosage can result in big changes in blood levels because the small change results in a lot more drug being given that can't be metabolized. So one of the things we find is that simply someone has a person on 300 milligrams per day, bumps it up to 400 milligrams a day, which doesn't seem like a big dose increase. And those individuals suddenly have a lot of toxic effects. One of the big concerns there is that the liver, because the liver is maxed out, is that majority of that drug does not, get metabolized, which then causes the effects that we're seeing. Most of the drug interactions with phenytoin we're concerned about typically are related to either protein binding, because it's very highly protein bound, so it can be bumped off, or metabolism. We do see that in renal disease, we see that the protein binding tends to be lower, tends to decrease. And another thing about phenytoin is it can give us some false readings on the on thyroid tests. People on phenytoin, if they take the thyroid test, if we don't know you've taken the phenytoin, we have a problem. So fortunately, we typically are measuring TSH as well as T3 and T4. So that's the typical standard. So that's a way we can get around it. Here is a key thing about most of these anticonvulsants. Put this in the back of your mind. Many of the anticonvulsants are enzyme inducers, okay? So one of the things that you have to be careful about if someone is taking an anticonvulsant, like phenytoin, I'll mention some of the others, they can induce the enzymes, which means that other drugs may be metabolized quicker. I'm going to check chords here to see if that helps. So the chords seem to be fine. So let me know if there's any change in mic sounds. I will tell you that usually my mic filters this out, but Big Al is over in the corner and he is snoring a little bit. So if it sounds like a dog snore or a little heavy breathing grunt type thing, that's him breathing. So, but usually the mic doesn't pick that up. So, so one of the big things to think about with anticonvulsants in general is many of them are enzyme inducers. So that means that drugs that go through the same enzyme can be metabolized quicker. It also means that sometimes they will induce their own enzymes, which means when they are on, when you are giving them these drugs, over a period of time, is they will start metabolizing these drugs, metabolizing themselves faster. So with phenytoin, we've got protein binding as a potential drug interaction. We've got enzyme induction, and we've also got that it can interfere with some thyroid tests. Significant toxicity with phenytoin. Again, we're making a benefit risk anytime we're using these anticonvulsants, because the issue becomes when we're dealing with someone with seizures, we're really willing to take a little bit more chance with regard to the side effects, or we'll tolerate a little bit worse side effects. What we do in these cases is what we primarily are going to do is try to monitor and keep the dosage low is one of the big things. One of the things we see is people may see very early after being put on phenytoin is they may have some nystagmus. Their eyes seem to jerk a little bit. Typically, that is not going to be too much of a problem. Doesn't usually require a dose decrease. But what we do see is sometimes people have double visions and have difficulty walking. And when you've got double vision and ataxia, that can be a significant problem for people getting around. Elderly people, you don't want to chance them falling. What we typically are going to do is those usually respond to a dose-related change. So what we're going to do is typically try to lower the dose and see if these go away. Okay. Gingival hyperplasia occurs. That's where the gums basically swell up. Those don't reverse. There are a few people that are rare that, basically don't have to have this dose adjustment. The gingival hyperplasia. It doesn't really cause any problem. Biggest problem, I would think, is appearance. The other thing that we would see is with gingival hyperplasia is that sometimes dental hygiene is a little bit more difficult. Patients sometimes develop hirsutism, so they get hair growth. But one other thing we need to be aware of is if they're using phenytoin chronically, basically we can see some abnormal vitamin D metabolism, and we may get some osteomalacia. So we start getting some bone softening. So one of the things that people try to do is phenytoin was a good drug, had a lot of side effects. The pharmacokinetics being zero order as you increase the dose, where that a small dosage adjustment, those were all things that were problematic. So people tried to develop derivatives of phenytoin. We saw mephenytoin, ethitoin, and then we had phenacimide, but that one's been withdrawn from the market here. Basically, what we saw is that they seem to be about as effective as phenytoin, but the clinical trials were not. There's not been any real good clinical trials that have really compared them. What we do see is that with these derivatives of phenytoin, we did see some severe adverse events that seem to occur more so than with phenytoin. Mephenytoin basically was worse as far as producing a dermatitis. This is a skin itching, skin rash. The more problematic issues was the agranulocytosis and hepatitis. So affecting the bone marrow and the production of blood cells, and the potential for hepatitis made it very difficult to use mephenytoin. We have to monitor for that. We did see ethitoin was, some people were very hypersensitive to the phenytoin, and so the ethitoin was a good alternative. It's not as effective because it's less potent. So that's really what you're doing is you're moving down. But if the patients just couldn't manage phenytoin and you needed to keep them on it, ethitoin was a legitimate alternative. Now, this drug is an anticonvulsant, but I want you to make sure star this slide, whatever, because this is a drug that you might prescribe, not as an anticonvulsant, but this one has been used as a mood stabilizer. Okay. So one thing I want you to be aware of is that its structure, it has a three-ring structure. It is like a tricyclic antidepressant in its structure. So in particular, its structure is similar to imipramine. Now, one of the concepts in pharmacology is that basically when two substances look alike, basically are very similar, one of the things that you are going to look, if their structures are very similar, one of the things that you're going to want to make sure is you can anticipate that there's a good chance that the effects of that drug, which include the side effects, may be very similar. So this carbamazepine structure is very similar to imipramine, which is a tricyclic antidepressant. So one of the things that we want to do is we want to be careful about using this with another tricyclic because we can have more side effects. Carbamazepine, as far as its anticonvulsant actions, it does block sodium channels, and those and any of the neurons that seem to have a high frequency repetition when they fire, this is blocked. In general, the drug works pretty well and is considered drug of choice. Now, I'm not going to ask you particularly what is the drug of choice for this condition or whatever, as I said before. Sometimes this is combined with phenytoin, but just like with, and we've seen carbamazepine used for treating bipolar, which we'll talk about that some more detail. It's also been used, it's had some effectiveness for trigeminal neuralgia. In general, tricyclic antidepressants have had some benefits there. But just like I mentioned earlier, this is another big thing that you want to be aware of, is it can induce the microsomal enzymes and increase the metabolism of other drugs. Notice we've got phenytoin. We're going to mention ethosuximide very quickly. Valproic acid will be another drug that you might prescribe for schizophrenia or mood disorder. And clonazepam, several of you will be prescribing clonazepam. So in particular, notice that this one induces the metabolism. So when you have drugs that are acting without being broken down or metabolized, one of the things that you've got to be careful about is just to be aware that these can, one, make the drug faster, metabolize faster, so you may have some subtherapeutic effects, and two, be aware that it can induce enzymes that's going to metabolize itself. So the longer a person is on carbamazepine, or just like phenytoin, is the drug may become less effective because it's being metabolized quicker. Side effects of carbamazepine can be significant. We do see some double vision, some ataxia. Typically, the double vision will be the first thing that pops up. For some reason, it appears that the diplopia seems to be, the double vision occurs, doesn't last a long time, may occur at a particular time of the day, every time. That may be related to, for example, its peak concentration. No one's given a exact explanation for that, but it's one of the things that if the person is having the double vision and it tends to occur about the same time every day, one of the things you do is you can arrange when you give the dose. So, for example, let's say the double vision was going to be seemed to occur with me. I took my morning dose and I'm getting ready to leave for the office at 9 o'clock. And so I have a period of, between 9 and 9:30, I'm having double vision. Well, one of the things that I might want to do is take the dose maybe a little later or a little earlier. So a lot of times by rearranging when we give the dose, or sometimes even maybe going to see if we can lower the dose, that may get around that. As I said earlier, almost all of these drugs are going to be CNS depressants. So one of the things that we want to be aware of is that drowsiness can occur. Where we're going to be worried about drowsiness is going to be when we first put them on the drug, and then we're going to also be worried about drowsiness when we increase a dose or maybe add or take away another drug. So it's going to be one of those things that we need to be aware of. One thing we can see too is we've seen what is called hyponatremia.
and this is also known as water toxicity. At higher doses, we see a problem with this. So what happens here is basically the person gets depleted of sodium, and so the sodium gets diluted out. This may be related to the sodium channels, but the net effect is that this is something we need to watch for, especially at higher dosages. We do see some of these individuals can develop a skin rash, an erythematous skin rash. That occurs. That can occur at any dose. But again, anytime we develop a rash, we want to make sure it doesn't develop into something that is that progresses to more serious life-threatening rash like Stevens-Johnson or toxic epidermal necrolysis. Probably our biggest concern with one of the biggest concerns we have with carbamazepine and with idiosyncratic, what I'm referring to is that basically it can occur at any dose. Typically, people talk about idiosyncratic being associated with the immune system, but there have been, when I say blood dyscrasias, what I'm looking at is those are blood disorders that occur. And what we've seen is that there have been some fatal cases of aplastic anemia and agranulocytosis. So that is going to be something that we need to watch out for. So one of the things that we see there's part of a black box warning with regard to this, and I'll go over this again when we talk about the advanced pharmacology about you prescribing it. But what we find is that the black box literally says that the risk of developing the aplastic anemia or agranulocytosis is 5 to 8 times greater than the general public. But they consider it a low overall risk in the untreated population. This tends to be, this can be transient or persistent. But basically what we need to do is we need to watch specifically for any changes in platelets, white blood cell. Those need to be monitored. So this typically is going to be monitored before you put them on the drug, and then you're going to monitor afterwards. And these blood dyscrasias, interestingly, is most of these have occurred in elderly patients that were actually being treated for the trigeminal neuralgia. We've not seen as many cases with those that were getting it as an anticonvulsant. Could it be dose? I don't know. But that's just one of the things that occur. The other thing is, especially the first 4 months, is that's when they tend to occur. Doesn't mean we drop our guard down after the 4 months, but it means that during those first 4 months, we may want to be doing CBCs a little bit more frequently. I want to go back to one other thing. When I said mentioned about this erythematous skin rash, they have now put on the Tegretol as a black box warning, serious dermatological reactions. And one of the things that we see is basically that there's about a 10-fold greater risk, specifically in Asian countries. And you guys will talk about this in more detail. But again, when we get to the advanced pharmacology, but those people that have the HLA-B 1502 allele, this is primarily in Asian patients. They are at a high risk for developing these adverse drug serious skin reactions. So now what they do is patients that are Asian patients, it's recommended that they be tested for this allele before even treating the carbamazepine. So that is going to be something we see with several of these anticonvulsants that you might use. Carbamazepine, lamotrigine, that's another one. So all of those carry that risk that we need to be aware of. Now, another drug, they took a derivative of this. This is very similar to carbamazepine. It's oxcarbazepine. It's less potent. It doesn't produce as much hepatic enzyme induction, so we don't get as much induction as we do with carbamazepine. And it seems to be, the toxicity profile seems to be a little bit better. So if you want to use or stick with carbamazepine, what they do is if the toxicity is an issue, they may go to the oxcarbazepine. Again, the question is going to be, do you get the same therapeutic benefit? And that'll depend on the patient. Now let's move to one of the oldest drugs that's been out there. This is probably one of the oldest anticonvulsants. It's phenobarbital. Okay, barbiturates have been used, but phenobarbital is a barbiturate. It is a scheduled drug. It basically has a number of actions to produce its effects. What we find is that it tends to enhance the inhibitory pathways, which is good, especially since you've got stimulatory phenomena you're trying to treat. It decreases or diminishes the excitatory transmission. So basically what we're doing is that we're pushing on the brake and taking off the accelerator. It may selectively, there's been some evidence that the neurons that may be damaged, that are firing too much, that they may be more susceptible to the effects of phenobarbital. And just like with phenytoin, that it also can inhibit sodium conductance and affect some calcium currents. So a lot of potential mechanisms with phenobarbital. Barbiturates, and this includes phenobarb, actually will bind to the allosteric regulatory site on the GABA benzodiazepine receptor. So that's how it enhances the GABA receptors, by binding. And then what happens is that these GABA receptor mediated currents stay open longer, and the chloride comes in, and that is one of the ways it does this. And then it seems to be able to block the glutamate pathway. These two actions probably are what most people believe are due to its anticonvulsant actions, because these occur routinely at what is considered the therapeutic concentrations. Used for a lot of different type of seizures. Especially some of these seizures that are hard to call. Phenobarb is one of those fallback agents. What we find is that although it's used for a lot, that there's a question of, for some of these generalized seizures, as far as it really being effective, there's a question about that. And some people have even suggested that it may worsen those seizure types. But it has been used for, again, we see it used, and there's debate on some of these other seizure types as to whether it would work. Again, I'm not going to be asking you on which ones do these use, or does this occur and is used here. All right, let's talk about one other drug, and then we're going to take our break this afternoon. So primidone. Primidone is sort of a prodrug in a way. It actually gets broken down to phenobarbital. I say it's a prodrug in a way because it gets broken down to not just one drug, but to a couple of substances. So primidone gets broken down to phenobarbital, so you're getting the effects of phenobarb. And another compound that is formed is called PEMA, which is phenylethyl-malonamide, okay? Primidone makes these metabolites, both the parent compound, the metabolites are all active. And these actions seem to be sort of a combination between phenytoin and phenobarbital. The biggest problem with primidone is that its toxicity, very similar to what we see with phenobarb, except we tend to have a little bit more drowsiness. And that drowsiness will occur pretty early in treatment. And the question is going to be is whether that person can function with the degree of drowsiness that we're seeing. That's going to be one of the big issues with primidone. All right, so what we've got here, we talked about phenytoin, we talked about carbamazepine, we've talked about primidone and phenobarb. All of them have some sodium channels. A lot of them are working through the GABA, so there's multiple actions here. And again, carbamazepine, we have some concerns with the toxicity. We can need to monitor for that. So let's take this will be our long afternoon break. We'll come back at 10 after the hour. And we're going to pick up on some drugs that are interacting with GABA. And so let's come back at 10 after the hour, and we will pick back up on this. Does anybody have any questions? Also, has the mic done better, or we still getting some weird sounds?
Okay. See you guys at 10 after. Okay, guys, let's go ahead and get back um, um, and go from there. So, okay. All right. So let's move on to some of these drugs, like I said earlier, they are going to interact with GABA. So vigabatrin is actually binds to GABA aminotransferase, and so it's an irreversible binder. So basically, it connects to this enzyme. Make sure I've got, yeah. So what the vigabatrin does is basically latches onto or binds to the GABA aminotransferase. This is the enzyme that is responsible for degrading GABA. And so as a result, what's going to happen is that the GABA, when it's released, is not going to be broken down. But what's going to happen, um, um, the issue that happens is the GABA increases at the synapse. So we have it's sort of like an acetylcholinesterase type drug, except it's with GABA instead of acetylcholinesterase. The other thing it does is not only does it increase the amount of GABA, but it actually potentiates the effects of GABA by inhibiting the GABA transporter. So it basically stays out there in the synapse. So here's a good example of a drug that basically is going to elevate GABA and potentiate the effects of GABA. And GABA is, as you know, a transmitter, inhibitory transmitter. The typical side effects that we see, again, CNS depressant. So we tend to see some drowsiness and dizziness. One thing that a lot of people don't like, but we do see it, is this weight gain. And so a lot of people do not like the fact that they're putting on weight. We can see, these are less common side effects, but these are important to note, is that although this is an inhibitory and tends to be CNS depressant, we do see that occasionally in some patients, we do see actually stimulation. We see some agitation, some confusion, some psychosis. This is, again, it's not the most common thing that we see. It is less common they come across, but because of these effects, what's happening is basically there was a little bit of pre-existing, if we've contraindicated if there's pre-existing mental illness. That's a big issue because of it would be difficult to tell if this was allowing the pre-existing mental illness to come forward, or if this was a side effect, or if it's a combination of the two. The long-term therapy with this drug, there is a concern about visual field effects. So one of the things is we're going to do an eye exam if we're going to keep them on this drug for a while. It can be irreversible, and so if we start seeing some changes in vision, this is going to be something that is there, that is that we need to be aware of, that we would need to move them off the drug if we did see changes in vision that's occurring. Now, this is a drug that you definitely want to know about. So just like with carbamazepine, put several asterisks on this slide. This is a drug that many of you felt like, basically you're going to see prescribing a lot. Okay, lamotrigine came out, and I'll tell you the truth, as I had seen some of the FDA documents with lamotrigine, and to tell you the truth, I really was surprised that it's been approved, but it has been used. And so what lamotrigine does is it is going to the neurons that are rapidly firing. This is what you would expect to see when a seizure is generated. What you're going to see is that this suppresses these rapid firing. So when we have seizures, the neurons will start firing rapidly, and basically as a result of that, that is going to those are going to be firing those setting up electrical circuits, which is causing the seizures. And so those rapid firing neurons tend to be more susceptible to lamotrigine, just like a lot of these other drugs. These seem to, the mechanism seems to be sort of a blockade or shutting down of the sodium channels. can possibly act on the calcium channels there. The calcium channel activity sometimes may be associated with some of its mood stabilizing effects. Typically, we see it added on. We have seen it used in monotherapy in some kids, in some patients. But again, you just need to know it's an anticonvulsant, but you'll also know it's a mood stabilizer. Adverse effects. Take a look at a few of these things that we need to be aware of. One is that we see some dizziness, headache, some double vision. That's been some things we've seen with some of these other drugs. Somnolence, another big thing, is sometimes they just seem out of it. Here's a key thing, just like with carbamazepine. Lamotrigine has a black box warning, okay, specifically for the skin rash and dermatological problems. And again, we will discuss this in much more detail, but just like with Tegretol, we do see that it can produce some serious skin reactions. In fact, Lamictal is very well known about that. The black box warning is specifically for serious rash. Pediatric patients are specifically at a high risk for this. And so anytime that there is a rash that occurs, especially requiring hospitalization, it's recommended that you discontinue the drug. Now, interestingly, with this one is we do see that most of these life-threatening rashes occurred somewhere between the first 2 weeks, the first 2 to 8 weeks of treatment. Some of them, there has been some isolated cases other than that. But one of the things is that there is a recommendation that you introduce the dose slowly. When I have seen the cases of Stevens-Johnson syndrome with lamotrigine, almost every instance that this has occurred, what I've seen is that it's where that people have escalated the dosage too quickly. So it is recommended that the dose increases. There is a recommendation dose escalation that's in the package insert. And what I've seen is basically that this people have jumped, and it's like they gave it or they started off with too high a dose, or they gave a dose and then jumped up and doubled the dose or something like that. So the biggest issue is that, especially for this drug, is you want to follow the dosing recommendation in the package insert. So some people argue that it doesn't completely, or there's not finite evidence that it's drug induced. But again, every case that I have seen over the last 5 or 10 years has occurred when somebody has jumped the dose, started too high, or when they escalated the dose, they were increasing it faster than what was recommended in the label. So we usually don't think of lamotrigine or of Stevens-Johnson syndrome and those being dose related, but with lamotrigine, there seems to be some evidence that there may be the case. Another thing we worry about with lamotrigine is that other drug interactions, so valproate or Depakote, if it's being used with lamotrigine, which can occur, it can increase the half-life by 2-fold. So there would be a form of dose escalation that you'd want to be careful about. The other thing would be is that these adverse events may be more commonly a concern with the situation that's with this drug interactions. So we're going to have carbamazepine, lamotrigine, Depakote. We're going to have much more detailed discussions with regard to them being used as mood disorders down the road. Okay. Now let's move to felbamate. Felbamate is a drug. This one seems to be a little bit different. It blocks the NMDA receptor by binding to the glycine binding site. This one is basically not used as a first-line drug. It's usually reserved to third or fourth line because of serious toxicities. So in particular, the concerns we have with felbamate are going to be severe hepatitis, aplastic anemia. So what we're going to need to do is we're going to need to be monitoring closely for these particular toxicities. We do know that there's some drug interactions. We do see plasma phenytoin, valproic levels go up. It can decrease carbamazepine levels. So again, it's one of those things where we need to be very careful with regard to the drug and drug interactions. Most of these anticonvulsants, because of the toxicities, we're going to want to be aware of the toxicities and the drug interactions that can occur. So just be aware of that, and it's always good to run a drug interaction check on these particular drugs, simply because that, you know, in some cases we can see that these drugs are going to the levels may go up, others may go down. Sometimes the other thing we run into is with these particular drugs is that we're going to see a situation where that in some instances it may go both ways. We may see that the drug induction may occur later on down the road. So when we're using these, and people that are using these to manage seizures have to be very, very careful with regard to these drugs because of drug interactions and because of either an increase or decrease. An increase in the drug levels can put us in with some serious side effects. A decrease can move us down to a subtherapeutic range. And when we get a subtherapeutic range, what we run into is basically a scenario where that we may have seizures reemerge. So these are real concerns that we have when using these particular drugs. Okay, so another drug which is I'm seeing used quite a bit for just about everything. Gabapentin is basically it is an analog of GABA. GABA is the inhibitory transmitter, and what gabapentin does is it alters GABA metabolism. Okay, it can basically alter non-synaptic release or reuptake. We know that gabapentin doesn't bind or act on GABA receptors, but what it does by these, either by altering metabolism or the release or uptake, is going to increase the GABA concentration. So this one's an easy one to think about. Gabapentin, think of a GABA, and it's going to increase GABA concentration. It also can bind to some calcium channels and interfere with calcium fluxes that come through into the cell, and that can be a part of its action. The thing was gabapentin, when it first showed up, what we saw was that gabapentin basically was developed and evaluated really as a drug to prevent or to alleviate spasms. So it was a spasmolytic. What we found was it didn't relieve spasms that much, and probably the spasmolytic component was more of potentially thinking about the calcium blockade. But we did see it wasn't that effective as a spasmolytic, but they did see that it seems to work as an anti-seizure agent, which seems to probably be more related to the effects on GABA. We've seen it used with other agents for treatment of seizures. Typically for treatment of seizures, it takes a pretty high dosage. Probably what I see gabapentin used more for is neuropathic pain. It's actually indicated for post-herpetic neuralgia. We see a lot of pain management being used with GABA. Here, I'm just curious from a standpoint of with you guys, how many of you have seen your patients are on GABA? Yeah, that's one of the things that we do see is that this, what I'm seeing a lot with GABA is, number one is that GABA seems to be, the docs seem to put it on for just about everything. Danielle, one of the things that we see is that, well, let me mention this thing first, is that every time there's pain involved, we see GABA putting on there. And it started off with neuropathic pain, And then we said Lyrica started picking up with this, but we then started seeing that. But one of the things that we do see is that a lot of people are using GABA and actually abusing GABA. Have you guys heard of GABA abuse? That's coming up. Okay, Daniel, you've heard of it. Geraldine, you've heard of it. So several of you have. I'll send you. I'll have. I think I have an article on GABA abuse, which I will post for you guys to look at. But that's one of the big things. One of the things with GABA is that the reason is it's not a scheduled drug, and on the other hand, a lot of docs think it's very safe. And the biggest thing I've seen with gabapentin from a standpoint is that people recognize that sometimes at high dosages it does produce some somnolence, but we've started seeing it a lot. Those of you that are seeing the people abuse it, what is their main, what do you see them using it for as far as when they're sort of abusing it? Some of them are basically are going to use it. So some of the pain that comes through that, yeah. So I'll get you this article, but that has been a concern with regard to there seems to be a concern that's sort of showing up on the streets a lot from a standpoint. And there's this question. That's what I was getting at too. Is the aspect of whether it was there's the concern that they're getting addicted to it. That term is being used. And but there's people that's arguing, but I'll get that article for you guys. I think it came out last year of the concern with GABA. I know we're starting to see it in recovery, a lot of concern in people that are in recovery with using that. But again, one of the things that we see is a lot of docs will prescribe GABA very quickly. They will give large doses. They don't seem to be very concerned with regard to this. So it is become a major concern there. A lot of people are using it between when they're using their drugs. They use the GABA to sort of as a sedative for going against that. The side effects, typically a lot of people tolerate GABA pretty well. Probably the biggest thing that we see is probably some somnolence that occurs. That's usually at the higher dosages or when they first start. Some people, I think somebody mentioned that sometimes they may be used as for sleep. Some people use the somnolence, the high doses, to help them get to sleep. We find it's really not metabolized. It's broken down into, when I say not metabolized, it doesn't go through the liver there. But the other thing is that reason docs prescribe this quite a bit is that there's very few drug-drug interactions. That has been more of an issue where that a lot of docs feel like it's a safe drug to prescribe because of the lack of drug-drug interactions. And so that is a big issue. When you look at its actual indications, it's been approved for seizures. It's been approved for the postherpetic neuralgia, neuropathic pain, and fibromyalgia. Fibromyalgia is basically used off-label. Has been used for alcohol dependence. When you look at a lot of docs like it because, again, that's a good point, Eddie, we're seeing that too, is that people are shifting away from opioids and trying to use more GABA with regard to it. When you look at the drug interactions, it's the biggest thing you worry about is other CNS depressants, but you're not going to see where that, it increases or decreases the metabolism of another drug. But we do see that occurring. Topiramate basically is going to be, this one differs from all of the other anticonvulsants structurally. So it's sort of unique. Even though with a different structure, it still blocks sodium-dependent channels. And this one also will potentiate the effects of GABA. This one binds differently than where phenobarb or benzodiazepines. And then it also is it depresses excitatory action of kainate on the AMPA receptors. So what we've got here is we've got sort of a sodium channel blocker, a GABA or an inhibitory transmitter increases and decreases excitatory pathways. I'll mention this now, but I'll mention it again when we talk about it in the advanced course, probably in the fall, is a lot of people took the attitude that, for example, some of these anticonvulsants were effective in treating schizophrenia and mood disorders. And so they then extrapolated, if these anticonvulsants are effective, they have extrapolated that all of these anticonvulsants can be effective. So what you see is several drugs that are being used that are anticonvulsants for treatment of schizophrenia or mood disorders. And there's actually no evidence-based literature on a lot of these. But they're anticonvulsants, and so since carbamazepine and several of the others have, the assumption is we can still use them. But again, we've seen a lot of people that are trying these other drugs, and the evidence is just not there. The topiramate is effective on a number of seizures. Again, I don't want you to be caught up in taking those, particular type of things, getting caught up in, which seizure is each drug used for. I'm not going to be, you're going to just simply say they're used for seizures. That's all I'm really care of. There may be one instance in a few minutes I'll talk to you about. But topiramate, the thing is the side effects are usually dose related. That's good, because if we can keep the dose down, we can minimize the side effects. If they're going to occur, they usually occur within the first 3 or 4 weeks of treatment. The biggest thing that we see probably is that topiramate can produce some somnolence. Patients feel a little fatigued. They're just not as sharp, sort of some cognitive slowing that occurs, some potentially confusion. But some people can feel some paresthesia, feel like things tingling in their skin or things like that. But the biggest thing we see is typically is going to be somnolence, or they're just fatigued. We do have to watch out for changes in the eye. Myopia can occur, glaucoma, and that has been one reason why topiramate has been potentially withdrawn, is because of changes in vision. One of the things, there's some suggestion that the drug can be teratogenic. That has been demonstrated in animals. We have not, I don't think, documented any case that I'm aware of that is based on human data. Does have some interesting drug interactions, but one of the things, typically what we find is most of the drug interactions result in the topiramate being less effective. But there is one you need to be aware of, is that topiramate can make oral contraceptives less effective. So one thing that sometimes is recommended is that if it's often recommended that individuals should use alternative forms of birth control. And so that is one of the concerns with topiramate, is it can decrease the effectiveness of oral contraceptives. If you look at topiramate, it seems other than the issues that we have is it seems pretty, other than being a CNS depressant for most part, it seems to be pretty predictable as far as the side effects that are occurring there. And again, being dose related, that can be a big, that can be favorable in the sense that we can adjust the dose. And sometimes the biggest question is, can we adjust the dose so that we get the same effect at a lower side of, with a lower side effect there. Marissa, just as a heads up, is probably in about around 5:45, maybe in about 9 minutes, 8 or 9 minutes from now, is we'll go ahead and do the 4-question afternoon question. If you want to, you may already have it set up, but probably just in a few minutes, we'll go ahead and let them take those questions. And then I'll go back and finish the lecturing, and then we'll finish up with the post-test on that. So just sort of give you a heads up there. So what we'll do is in just a few minutes, take a 5-minute break, let them take the question, or we'll combine the break and the question, and then we'll go from there. Okay. So one of the things that we find is when we're looking at another drug is tiagabine.
Tiagabine is another drug that was actually, when I say that it's rationally designed, this, I think I've mentioned this before, but what I mean by that is basically what happens is someone is consciously looking at the structure of the drug and trying to, based upon other structures, is to find where the binding sites are and how it interacts and try to chemically design a drug. That's what I'm talking about when I say rationally designed. So this one was designed basically as a GABA uptake inhibitor. And so the idea here is that by blocking the GABA uptake, you leave more GABA out in the synapse, so you have more of an inhibitory effect there. So this preferentially basically works on GAT1 or GAT1, GAT1. Doesn't affect the GAT2 or the GAT3. So the net effect is that we get an increase in the extracellular GABA, specifically in the forebrain and the hippocampus, where we see a lot of these seizures occur. And the other thing is, by blocking that, it prevents the GABA that's released from being taken back up. So what we have is a prolongation of GABA. We see increased levels, and they stay elevated for a longer period of time. This one is used typically with some other drugs as an adjunct. Notice the side effects are very dose related and very similar to what we've seen before. We do see some depression may occur, so that's something you might want to watch. Typically, we will see we do see patients that just, even at the lowest dose, seem to have excessive confusion, some somnolence, may have difficulty walking, so ataxia. And if that just seems like too much, then we just go ahead and basically discontinue the drug and try something else. You do need to be aware of that in some instances, psychosis has occurred. That's pretty rare when it occurs, but it has occurred. So that could be a drug-related effect. And just as one of the things that you need to be aware of. It is, from a standpoint of this, there's no black box warning. It's primarily been approved for use of seizures, and that's about it. And its use is fairly narrow in that it's for mainly for partial seizures. We do see some rash that occurs, and just like I've told you before, if rash is occurring, we just need to make sure to monitor to make sure that it doesn't develop. Another drug, which I don't have in red, you don't have to worry about it, is zonisamide. This one works on the sodium channel. Most of these that work on sodium channel typically are going to have some effect on the calcium channel too. Zonisamide is not basically has been used for a few seizures. It is got some concerns with side effects. What we find is that there's no black box warning, but we see a lot of times with zonisamide, it produces a lot of drowsiness and sort of cognitive impairment. But we have to be careful about the skin rashes can occur too, another one of those. But again, this one does not have doesn't have a black box warning. But under the warnings, it does have Stevens-Johnson and 10 as two of the most common things that we see there. Levetiracetam. This drug, basically, we do know that it binds to the GABA receptor. It can affect calcium and potassium channels. This one has been used for partial seizures. And again, we see one of the things with this one, why it has had some popularity, is because the drug interactions are very, very minimal. When you start looking at a lot of these drugs, you see a lot of docs get concerned with the drug interactions. And that is when they find drugs that have minimal drug interactions, they seem to like to try to use these. The biggest thing you worry about is it is a CNS depressant. And being a CNS depressant, it basically can produce, have an interaction with other CNS depressants. So adverse effects are very similar: somnolence,
asthenia, dizziness that we've seen with some of the others. All right, so this is a good place for us to maybe take a break. So let's do this. Why don't you guys take a 5-minute break? And then, Marissa, why don't you go ahead and put up the quiz? And I will come back and finish up lecturing, go over the quiz, and come back on the hour. So you've got about 14 minutes. So take about a 5-minute break, take the quiz, and we'll start the new material, pick up the new material on the hour. Okay? Okay, guys, let's go over these questions here. And you were true. We had not covered one in detail, but again, we'll use this sort of as a just as a takeoff to mention that too. So, with regard to the afternoon questions, question number one: insulin is formed in which cells? The correct answer is the pancreatic beta cells, which is D. Number 6, blood levels of anticonvulsants correlate with therapeutic levels. This one is not the best question because basically there is no direct correlation, but what we do see is that we do know that the therapeutic levels are there, but we can't say that we'll get this degree of protection at this. So the answer that I gave was basically that it's false, but there could be a case made for true. So that was a poor question on my part. Question number 3, which of the following is structurally related to tricyclic antidepressants? The correct answer here is C, which is carbamazepine. One of the reasons that you don't want to, you want to be careful if you're using those two drugs, a tricyclic and the carbamazepine, because there could be a thing. And then the last question was with regard to valproic acid. What it does is it actually increases GABA levels. So although I hadn't covered it, the fact is most anticonvulsants actually increase the GABA levels. Could have been a good guess. So let's pick up and let's finish up the next few slides that we have. And then and I'm going to send you guys that article on the GABA. So we'll post it on Moodle, but you won't need to, to basically do anything with regard to it, but I do want to cover these other drugs here. In other words, I won't test you on it, is what I'm saying. Okay. So all the drugs we've talked about have been used previously have been used primarily for partial seizures and various other types and some on general seizures. These that we're going to look at are ones that are primarily used for people that have had generalized seizures. So we have the suxamides, which are, make sure I'm on that's my first slide. Jumped. Yeah. So we have the suxamides includes ethosuximide, finsuximide, methosuximide. Then we have the valproic acid and sodium valproate, which is Depakote. And then we have one last class, which is the oxazolidinediones. So ethosuximide basically is acting on calcium currents. What it does is that there's these T-type currents, which are believed to set up a pacemaker cell in the thalamic neurons. And so a pacemaker cell is a cell that's automatically discharging. So what we think happens is in a generalized seizure that there can be these pacemakers that set up that start generating a rhythmic cortical discharge. These are what's occur in an absent seizure. And so by reducing these calcium currents, that would shut this pacemaker down. We do know at higher concentrations, we start seeing inhibition of sodium potassium ATPase, which is going to affect the ionic conductance. We do know that GABA aminotransferase is going to be inhibited, which is going to allow GABA levels to go up, and that the metabolic rate of the cerebrum is going to basically be depressed. But we think that at therapeutic dosages, what this is probably its mechanism is due to its action on these T-type calcium currents. One of the things with these is that one concern is that there is an interaction that has been identified with valproic acid. And so one of the things that valproic acid can do is that it can elevate the ethosuximide blood levels. That's probably due to a inhibition of metabolism as well as decreasing the clearance of it. So if valproic acid is being used, ethosuximide levels can be elevated due to this drug interaction. So we need to be aware of that when we use the combination of those two. The most common side effect associated is gastric distress. And the reason that prevents once a day dosage is because what literally happens is the dose that we would need to give for once a day
it creates too much gastric distress. So what we typically are going to do is going to start low and try to slowly increase the dose. The idea is to try to find the lowest dose and also to allow the patient to sort of get accommodated to the GI actions there. But what we typically see with this is we get a lot of dyspepsia, so indigestion. We get some nausea, vomiting, some bloating or abdominal pain. And so what you start doing is you increase the dose, slowly increase it slowly. If the gastric distress does occur, then you basically reduce the dose, then try to reduce it back up again a little bit slower. But really, that's the most common thing that we deal with ethosuximide. We also see other things which are very similar. We see sort of same fatigue, lethargic. Interesting, we have seen some people that have reported euphoria, and we've seen people that have reported hiccups. But we also see some idiosyncratic effects, skin rashes like SJS. Pretty much all these anticonvulsants, there's a concern with skin rashes and that sort of thing. So that's another one of those things to be aware of. And also, there's a question that there may be some blood dyscrasias, such as some aplastic anemia. This drug does not have a black box warning identifying any of those or addressing any of those. The other suxamides, which are the fensuximide, methosuximide, the methosuximide tends to be the more toxic of the two, but the fensuximide is less effective. So it's probably a potency thing where that the toxicity and the therapeutic effect are acting on very similar actions there. What happens with methosuximide is that it's broken down, and there is a metabolite that is produced, and that is it's the metabolite of methosuximide that is believed to actually produce its anti-seizure effect. The fensuximide doesn't get this metabolite, and it doesn't allow it to accumulate. So therefore, that is why that they think the fensuximide is probably less effective and also less toxic. This drug is of these major ones. This is one that I want you, again, this is put an asterisk because this is one that this is one that you would be prescribing to, which is valproic acid and Depakote. I realized I hadn't had the chat board on there. Okay. So it looks like we're having our late afternoon, potentially system issues. Let's hope it will hold out long enough for us to finish here. But the valproic acid and sodium valproate, these are basically the same drug. They're different formulations. The blood or tissue levels don't correlate well. That's what we get back earlier. But what it tends to do is this will sustain when you have these high frequency repetitive firing. This is what happens during a seizure. It blocks these. So these actively firing cells, it sort of suppresses those. It has an action on sodium current, so it's similar to some of the other drugs that we've used or we've talked about earlier by blocking the sodium channel. What we really see with regard to this is probably we're going to see an effect on GABA. So we see that it blocks the excitatory actions by blocking the NMDA receptor, but it increases brain GABA levels. Okay, that's the answer to your fourth question today, which I hadn't covered. So one of the things it does is valproic acid will facilitate glutamic acid decarboxylase. That's an enzyme that actually is involved in GABA synthesis. So one of the things it's going to do is it's going to increase GABA synthesis. And the other thing it does is it blocks that GAT1 transporter, which prevents the GABA from being taken up. So you're making more GABA, and at the same time, you are leaving it out in the synapse for a longer period of time. There's even some suggestions that this valproic acid can hyperpolarize the membrane, and that may be due to potassium channels. So it is one of those things where there's multiple mechanisms that may be involved with valproic acid. Um, we see it from a standpoint of, again, I'm not going to ask you on anything about this slide here, but we do see that what we find is that it'll work on a number of seizures. It's worked for absent seizures. It's used if a person has generalized tonic-clonic seizures. We find that the ethosuximide may be used for uncomplicated cases. The biggest concern as to why it may be preferred is because of, with valproic acid, you do have some hepatotoxicity. The big thing with valproic acid is we see it used in a number of conditions. So you'll talk about its use in bipolar, or we'll talk about that later in the fall. It's been shown to be somewhat effective for prophylaxis of migraine attacks. But one of the things that you got to be aware of is basically there's some significant toxicities with valproic acid. Okay. One is we get a lot of GI upset, and some of that toxicity can be reduced if it's given after meals. So one of the things that we want to do is typically provide this after meals, and it's suggesting that some of the other toxicities may not be as bad. This may be due to the meals slowing the absorption. This is very highly protein bound, so we have to worry about drug interactions where other highly protein bound drugs could bump off the valproic acid. And then one of the things that people have done to sort of get around some of the toxicities is it's divalproex sodium. And this is a formulation that it's got, it's a ratio of 1 part valproic acid to 1 part sodium valproate. And getting with this given after meals about the toxicity, a lot of patients prefer this one because it's absorbed more slowly. So what happens is that you don't get as high a peak levels, which are associated with more toxicity. And because this one tends to be a little bit more gentler on the GI tract and the toxicity seems to be somewhat abated, more patients prefer the divalproex versus either the valproic acid or the sodium valproate alone. At low dosages, it's going to inhibit cell metabolism. So at low dosages, it can accumulate. But what we find is that when you get to the higher dosages, we see that there is a increased free fraction of valproate, which means there's more available to get to the tissues and produce it. But it also can inhibit the metabolism of phenobarb, phenytoin, carbamazepine. Now, here's where you get sort of this complex component. Is you've got one drug inhibiting, you've got other drugs that are inducers. So that can sometimes create problems that we just need to be aware of and be aware that patients may, if side effects emerge, just or if it's subtherapeutic, we just have to be careful and watch that very closely. Most common side effect we see is simple GI upset. Okay, again, the divalproex or taking after meals will help this. A lot of people will complain specifically of heartburn and a lot of nausea, but also some just abdominal pain, sometimes even vomiting. But it is generally, that's one of our biggest concerns is the consideration of whether the patients will tolerate the GI problems. And even with seizures, it's a problem, but when you guys get to bipolar treatment and stuff like that, that is going to be a real concern. Typically, this drug, compared to some of the others, we don't get as much sedation. If it's combined with something like phenobarb, yeah, because one of the things, getting back to this, is it can inhibit the metabolism of phenobarbital. By doing that, phenobarb can accumulate. We do see a fine tremor at some of the high doses. Some people, that can be a problem with people that sometimes it concerns them that there's a tremor. Again, this usually happens at high dosages. Some people that have to use their hands for fine manipulation or writing or art or something like that, this may be sort of a deal breaker because it may interfere with their livelihood. Another thing that we see, weight gain. A lot of people will put on weight, their appetites increased. We may see some hair loss. These are all reversible effects. Sometimes by lowering the dose, we may not get as much, but it is a concern with regard to these patients. We do see a concern with hepatotoxicity. It's, I think, part of the black box that we see on this drug. It does have a black box warning. And um, the hepatotoxicity, basically, we saw a higher incidence when this was used for kids under 2 years of age. This was commonly used as a anti-seizure medication in these young kids. And it usually is going to occur in the first 6 months after starting therapy. People are, if the patient is on multiple medications, we do see the problem with it more being, I mean, it's a greater chance of it occurring. People that have died as a result of that, usually that's occurred within about 4 months after starting therapy. But the greatest risk, I mean, typically what we're going to see is if you're going to put these patients on this, we're going to take liver function tests to make sure that there's no problem to begin with, and then we are going to monitor that fairly closely. Just because you get after the 6 months, 4 months to 6 months, you still want to monitor that. Don't just drop the monitoring on that. We also see a thrombocytopenia that can occur. Thrombocytopenia is basically a situation where that your platelets are decreased. The problem with that is that the platelets can result in bleeding if you don't have enough platelets. The black box also will mention about a pancreatitis. I didn't have it mentioned, but there is a life-threatening pancreatitis that can occur. And this has been reported both in kids and adults. Anything that if they're complaining of abdominal pain, nausea, vomiting, anorexia, then basically, you know, some of those are common GI effects that we see, but those you need to check to see if there's any pancreatitis that is occurring. So, and then use a different drug if that's the case. We also see there's a fetal risk. This is part of the black box. What we find is these are primarily neural tube defects. We see spina bifida. We see some defects in the cardiovascular system, and the orofacial and digital abnormalities have all been identified. So those are the black box components that we see. I didn't put pancreatitis, but it is considered there. So valproic acid works pretty well, but it is, you know, we do have to be careful with it. Now let's move to another group, which is the oxazolidine diones. This is they all end up with ethadione. So we have trimethadione, paramethadione, dimethadione. When some other drugs, the succamides, came in, basically these have dropped in their use. What these basically do is they raise the threshold, so it's harder for the seizure to discharge. We see that dimethadone actually is very similar to ethosuximide by suppressing the pacemaker. But again, these drugs, they're not in red because their use has diminished quite a bit, simply because the succamides have replaced them. Typically, we see sedation is the biggest problem, but we see what is called humoral opia, which is the individual, they just have this glare. They call it a glare effect. And so that is one of the issues. Basically, their ability to for their vision to adapt for near and far and different lighting conditions is impaired, and that was another reason why that these drugs have dropped their effect. So what the glare effect is, just to give you a little bit more information, is basically when you look at something, it's an illusion where that the white region appears to be sort of self-luminous, and then it's got a lot of different luminous ramps that are occurring, and so it makes it difficult for them to see, and especially in bright light. And so that is their ability to adapt between dark and light is also affected there. It is reversible, so when the drug goes away, this could affect someone's ability to work, some people's ability to drive at night, and things like that. Don't want to use these in pregnancy. Now, so we've looked at the main drugs. So let's look at some drugs which we'll also cover a little bit more detail, probably with anxiety.
But what about sort of short-term management of some of these seizures? We used to see the benzodiazepines used quite a bit. We see them used more so in the hospital now. So, for example, Valium or diazepam, very effective at stopping a continuous seizure activity. See this used in the ER room quite frequently. The problem is that to give someone as a prophylactic, this doesn't work real well, because what happens is by giving it orally, pretty much on a daily basis, multiple times a day, basically they'll develop a tolerance to it. So we see diazepam used on a short-term basis to primarily stop seizure activity. Then what they try to do is figure out what's causing the seizure and what type of seizure it is, and then put them on one of these oral medications we've talked about this afternoon. Lorazepam actually can be more effective. One of the things that we see is that it actually is longer acting than diazepam. Specifically, it is pretty good for use in status epilepticus. And what we see with status epilepticus, I talked to you about it, is these can be life-threatening seizures. Another drug used is Klonopin, clonazepam. It's longer acting. It's used for different types of seizures. With all the benzodiazepines, one of the concerns is basically sedation, especially early on. But again, one of the things becomes we get a tolerance that builds up. The other issue you're dealing with long-term is the potential for people becoming addicted to it. Clorazepate is used, but again, usually we see one of the other drugs, either Valium, lorazepam, or clonazepam. Most common thing with the benzodiazepines is typically drowsiness and lethargy, especially early in treatment. Which agent we use really comes on is based a lot on their pharmacokinetics. Most of these are pretty well absorbed. They get distributed throughout the body. They get metabolized. Some have active metabolites, which we have to worry about. But we do see pronounced sedative effects in most patients. There are, in fact, I've got two patients right now that I'm aware of that I've been asked with regard to this, that actually drugs like alprazolam and both of them involve alprazolam, where individuals, not children, but actually developed paradoxical hyperactivity. And so there has been some concern that people have overlooked this paradoxical hyperactivity, which can occur, can result in some aggressive, sometimes violent behavior. So most people will see sedative effects, but we can't rule out that there may be individuals that may actually have the paradoxical hyperactivity. In one study I saw, the alprazolam was compared to diazepam, and we actually saw that the alprazolam was more likely to produce the paradoxical activity more so than diazepam. Tolerance will develop, so you lose its benefit, and those are concerns. But a lot of concerns with this is basically people becoming addicted to these drugs. A couple of other drugs that have been used, just to mention them, cetazolamide is actually a diuretic. It acts to inhibit carbonic anhydrase. So what it does is it produces a mild acidosis in the brain, and that mild acidosis basically will suppress the neurons. Also, we get it suppresses some of the ion channels, so that's how it does. People develop a tolerance to it pretty quick, so it's used on a very limited basis. Other things, if you look at different drugs of choice, I'm not going to ask you, which drugs of choice are used for the particular seizures on here. One of the things is that what we tend to see with most of these generalized seizures is we tend to try to limit the sedating drugs, the really sedating drugs, which typically is phenobarbital and the benzodiazepines. Again, not going to ask you on any of these as far as which particular drug is used, but I've given you it for your information. Let's see. Yeah. So I mentioned status epilepticus. Let's jump to this slide here. This is the most common form that people exhibit a tonic-clonic seizure. This is a life-threatening emergency. And what we typically see is diazepam probably is the most effective, probably more potent in terminating the attacks. The problem with diazepam, it's shorter acting. So what we may see, if there's a concern that this may be a prolonged episode, they may use lorazepam, but either diazepam or lorazepam can be used. What I've seen used most of the time around here has been diazepam. Phenytoin can be used. It's not sedating. Has to be given IV. One of the big problems is there's a tendency to underdose, and we have to monitor cardiovascular parameters and respiration, which we should be doing anyway. And when I mentioned to you earlier, one of the problems we have, especially with giving it IV, is some of the toxicity that we see is actually due to the diluent. Remember, phenytoin is not very water soluble. So what they do is they dissolve it in propylene glycol. So it's believed that some of the toxicity that we see with phenytoin when given IV is really not so much phenytoin, but actually the propylene glycol. So what a lot of people, when they have to give it IV, they preferred many times to use fosphenytoin. And the reason for that is it's more soluble, water soluble, so you don't have to add in the propylene glycol. Phenobarb has been used in patients that don't respond to anything else. Again, the issue with phenobarb is it's going to be probably more sedating than the others. With all the anticonvulsants, there is a concern with teratogenicity. Phenytoin, there is what is called a fetal hydantoin syndrome that has also been associated with phenobarb and carbamazepine. I mentioned in valproic acid, the neural tube defects like spina bifida, and also some of the cardiovascular and the orofacial concerns there. And so it is a concern. Topiramate, we don't have any human studies, but there were studies that were demonstrated with in animals. That always throws a question there. I meant to tell you the fetal hydantoin syndrome. What that is, it's a group of defects. It's sometimes basically there's a number of defects that occur, and there's mental and physical birth defects that occur, and that's directly related to the what's it called, the use of the drug. But these can occur. There can be things like cleft lip, cleft palate. There can be ocular eye defects. There can be some limb defects, growth abnormalities. So there's several different defects that occur with the fetal hydantoin syndrome. One of the big concerns we have when we're treating patients with anticonvulsants is, do we keep them on them all the time, or when do we withdraw them? So one of the concerns with withdrawal is going to be if we take the drug and we have not corrected, or the patient still has potential for seizures. When we withdraw the drug, we can see seizures return, seizure frequency recurrent. So when we're looking at these drugs, what we're looking at is basically, do we need to take them off? One concern is if the patient is doing well, there's no real side effects that it's creating major problems, we may not want to take them on there. So you got to, if we do have a patient that's having some side effects, we have to be aware as if we're withdrawing it, that these seizures can increase. So what we find is it's really got to be an assessment as to whether we need to take it off and whether we need to continue it. It really is going to be that decision, okay? That's why a lot of people that's managing these, or this is what they focus in. They're, epileptologist is the term that you see used. Typically, people that are on anti-absence drugs are usually easier to withdraw than those that are on tonic-clonic seizures. If the patient has been seizure-free for 3 to 4 years, then typically most people would say withdrawal is probably warranted. One of the things, if they're on barbiturates or benzos, those are probably the most difficult to withdraw, and that may actually take weeks or months. You may be dealing with addiction. You may be dealing with several other things that are occurring there.
As far as all of these anticonvulsants we've talked about this afternoon, when people overdose, typically what we find is that most of the overdose is due to CNS depression. The biggest concern is respiratory depression, and if alcohol is involved, this can really potentiate it. The big thing is do not use stimulants to treat. We've had people do that in the past. The CNS depression is occurring, so what they do is they try to give them a stimulant to sort of wake them up. The problem with giving a stimulant in an overdose is that you can recreate or you can reinitiate seizures. So you don't want to use stimulants to treat overdose, but there has been instances where people are CNS depressed to try to give a stimulant to try to wake them up. So you don't want to use those stimulants. In the lay public, they try to use things like, caffeine and large doses of caffeine or something if somebody overdoses. But you don't want to even use caffeine for this. All right, so focus on the, and Marissa, if you want to go ahead and get the post-test up. So you guys focus on the areas in red. Again, do not get caught up and don't worry about the only drug use that I'm going to talk about that I might ask you on the test is on status epilepticus. But I'm not going to ask you, which drug is used for generalized seizures, which drug is used for a partial seizure or an absent seizure. So let's see. I think, if I'm not mistaken, Marissa, do you remember when we meet next week? I think on my schedule we have that it is next week is our last session. And I will get with them as far as when we'll get you, I'll see how we can spread the test out. I will have the test up or to Marissa and Aiden probably by Tuesday. So I'll have it up pretty quickly, and I will check with Judy what the schedule is to give you all the most amount of time to finish that. So we'll try to set that up for that to expand that to give you some time. Okay. Any questions before we go? Let's see. Yeah, what we're going to try to, I would anticipate, Jordan, that we would do that is we're going to try to give enough time to do that. So the post-test will be, you guys are going to take the post-test right now. And so you should have that. And then after the post-test, then I'm assuming you're talking about the other. So I'll also try to have the slides up a little bit earlier this week for next week, so we can do that. So I was thinking that same thing, Kiara. So I will double check that, but we'll try to give you the maximum amount of time we can to finish the test. Okay. All right, Marissa, if you want to, I'm going to go ahead and log off. Marissa, if you want to put the post-test up. The rest of you, I hope you have a good week. And if you have any questions, feel free to email me. And we are almost have another class under your belt. So you guys are moving right along. Okay. Y'all have a good week. And Marissa, I am going to try to get you the test by Monday night or Tuesday for this material, and I'll try to get the slides up. Just let me know if it's going to be you or Aiden or the next session, so I know who to send the stuff to. I usually copy both of you anyway. So, all right, guys, y'all have a good week.